Welcome to the webinar this afternoon. My name is Ree Hui. I'm a Year 4 postgraduate student from Department of Family Medicine, UKM, and I'll be your moderator this afternoon. Welcome to the webinar titled Snake-Related Injuries, What a Primary Care Physician Should Know, and organized by the Department of Family Medicine, UKM, in collaboration with Remote Envenomation Consultancy Service, or REX, Malaysian Society on Toxinology, or MST, and College of Emergency Physicians, or CEP. We are very fortunate to have the foremost expert in snake bites in Malaysia, Prof. Khaldun, to be with us this afternoon. So before we begin, allow me to introduce our esteemed speaker today, Prof. Ahmad Khaldun Ismail. He is an associate professor and consultant emergency physician. He is the founding consultant and advisor of Remote Envenomation Consultancy Services, or REX, and founding director and advisor of the ASEAN Marine Animal and Snake Envenoming Management, or ANSEM Symposium. He is a member of WHO Global Roster of Expert and Technical Advisory Group on the Prevention and Control of Snakebite and Venoming. He is currently an honorary scholar at Graduate School of Medicine, Tohoku University, Sendai, Japan, honorary consultant at the National Poison Center, University Science Malaysia, and a resource person expert at the Malaysian Biodiversity Information System, MIBIS, Ministry of Energy, Water and Natural Resources. He was the president of the Malaysian Society on Toxinology from 2013 to 2021, and a review advisor for the WHO Snakebite and Venoming Working Group from 2018 to 2019. His special interests are in clinical toxinology, emergency medicine, and pre-hospital care. He founded various educational programs related to clinical toxinology for the public and healthcare professional. He is passionate about teaching and frequently invited as a speaker in Malaysia and internationally. He holds the authorship of several academic publications in related area of interest, and he also enjoys traveling, nature, swimming, and good coffee and tea out of work. So without further ado, may I invite Prof. Khaldun to give us the talk.
Okay, thank you, Riwi, for a very kind introduction. Welcome everyone. So we're going to have a bit of a short discussion about snakebite in general, or snake-related injuries. So in Malaysia, we noted that it's not just about bites. The injury that can occur from snakes, there are various injuries. So we classify them into what we call as snake-related injuries. Okay, so let's find out what they are. But first, we always begin with a bit of agenda so that we know where we are heading. So I'm going to talk a bit about definitions of what we mean by venom and poison, but in particularly what venom is and how it affects in terms of our approach to the subject matter. So that will be under what we call, or we term as safety and health-seeking behaviors, which is a very important aspect in how we should approach such a public medical issue or public health issue. So and then of course this is very specific to our primary care physicians or budding young primary care physicians. So we're going to talk a bit about what to expect from the public when, let's say, we receive patients in our clinic. And I assume many of you are also placed or attached to quite remote areas, not just in big cities. But mind you, in Malaysia, most of the cases also occur in populated areas, not so much in what we call deep forests and so on. Yeah, so that's very interesting because snakes are what we call cosmopolitan. So we are seeing snakes more in where human population is. Okay, so on top of that, we're going to look at what we have found in our research, and also what are the recommendations that we can utilize in order to support our primary care physicians out there. Okay, So the approach is slightly different. We're not going to talk in depth about what's happening in the hospital, but this is mainly to empower our emergency physicians, emergency family medicine physicians on how to deal with if they receive such a patient in their clinic, okay, or in their centers. Okay, and I believe that some of our participants are also from all over the world. Welcome, and I would like to also welcome public participations out there, because some of the information that we provide here may actually help increase the awareness in the public about safety and health seeking. Okay, all right, so let's move on to my first slide. What is a toxin and poison and venom? So as you can see, people think to lump all of these terms together, but in effect, they are actually different, and they have their own specific terms for its use. So the most general one is what we call toxins, and toxins is different from toxicants. Okay, so that's why we have toxicology and we have toxinology. So for toxinology, we deal with naturally produced substances, meaning that from living animals or living organisms. And these substances can actually cause harm if it enters our body. Okay, so these toxins can be either causing harm to humans, but mainly the toxins produced are also used to defend or to produce to get prey from other organisms. Okay, not necessarily humans. We are just accidental in a way of the function of the true function of toxins. So toxins can be divided into two. One is poison and the other one is venom. So for poison, it's very common understanding that we have to ingest, or we have to absorb, or we have to breathe in, or this substance before it can cause any effect. But for venom, it's very specific. It has to be injected into an organism to exert the effect of what we call as envenoming or envenomation. So that's the two main differences, which is how the toxins enter the body or the animal will determine the term that we use for that particular substance, whether poison and venom. And mind you, some animal also have both. They have poison, meaning if they are eaten, they can cause harm, or they also have a defense mechanism or mechanism to deliver venom. Okay, so that's very interesting. So in the picture here, you can see it's a bee. A bee is venomous arthropods. So it has a stinger, and it has a venom sac, and when it injects the venom through the skin, it will actually cause various multitudes of clinical symptoms, okay, of envenoming. Right, so venom itself is predominantly protein-based, and some of it are, for example, metalloproteases. Some of them are actually specific peptides, and that those are in the form of, let's say, for example, enzymes. And these are predominantly causing other effects in the body of the animal, either both to exert the intended paralyzing the prey, or it can already start digesting the prey. Okay, so and when it translates to what happens to human, some of these effects may or may not appear. So depending on actually what is the primary use of the venom. So most of them, majority is for predation and for defense. Okay, so so if a human bite someone else, another person, we don't classify ourselves as a venomous animal. Yeah, so even though our saliva contains some toxins that can cause harm to other humans, especially also some bacteria. Yeah, but we don't call ourselves as venomous organism. But these organisms that has venom actually very much what we call use it for the functionality of their daily use, or their survival in obtaining food and for defense. Okay, so that's very important thing to understand what venom is. Okay, so a venomous animal doesn't cause an animal may not cause a venomous bite. So the term venomous bite is actually not correct. Yeah. So when we say it's venomous, it's only refer to the animal. Okay, doesn't refer to the action of the bite. Okay, and doesn't refer to the effect to human. So that, just to make things a bit more confusing, because we are using terms out there very freely without understanding what it means. So we see a lot of confusion where we say, "Oh, this is a venomous bite," So then, this is a highly venomous animal, where we are referring it to the effects on human, which is actually wrong. Okay. Okay. So I think enough confusion there. The term is supposed to be making things more clear, but I think many are actually a bit more confused after that. Okay. But in general, basically, an animal has venom, we call it as a venomous animal. And an animal that does not contain this chemical and the specialized what do you call apparatus to deliver that particular toxins, we call them as non-venomous animal. Okay, so how it affects the humans is another separate area. So if it affects human after injected into their body, into us, we term the effects on human into what we call as level of hazards. And from the hazards or the clinical effect on human, we can actually classify the bite or the entry of the toxin into the body as harmless or potentially not dangerous, meaning it can cause some clinical effect, but without causing significant morbidity, or the ones that can cause significant morbidities, like for example, tissue damage, okay, or even death. Okay, so this most likely causing multiple organ failure. Okay, so the most common that we see in terms of a bite or sting from an animal is the clinical symptom of pain. So that's the main what you call significant early how should I say clinical presentation that they will present. So pain. But mind you, not all venomous animal causing pain when they bite you. Some of them actually, for example, in terms of snake bite, sea snakes or very potent neurotoxic venom snake, for example, the kraits and some coral snakes, they may bite but doesn't cause much pain because their venom is highly neurotoxic and it doesn't actually cause so much local tissue inflammation, which reflects in terms of which translate into pain. Okay, so suddenly someone may get a kind of a sting, not so much of local pain, but about 30-40 minutes after that, then they have manifest symptoms of neurotoxicity, for example, difficulty breathing, ptosis, muscle paralysis, and so on. Okay, and of course leading to difficulty breathing and death of asphyxiation. Okay, so knowing those potential signs and symptoms of envenoming, we actually had alert, so-called encourage our public, or we try to disseminate information to our public regarding what we term as appropriate safety-seeking behavior. Now, this term, safety-seeking, is a very active process whereby a person should undertake even before committing to an activity. So it's a prevention, okay? Mostly it's prevention. And and this is very important, and one of the process that we're doing today now is actually part of what we call safety seeking behavior. We are actually making it more aware for everyone to how to mitigate risks. So for example, if you go to mangrove forest, you already know that there are potential threats out there. For example, the mangrove pit vipers. They are very difficult to see, but they can bite and cause quite significant harm. So if you already know, for example, as a fisherman, they must take precaution in terms of look where they go, make sure that they wear protective gear, look where they are holding and touching, and also make sure that what do you call their equipment and so on is clear from all these potential dangers. So this is actually can be divided into 4 ways of how we manage risk there, which is a positive way, or negative way, or a reactive, means that you have already got bitten and then only you try to plan something, and that's a proactive way. So the best of all this is a positive and also a proactive indicators. Yeah. So an example that I can give, because I'm quite closely working with our colleagues in Japan, I noticed that they have a very high standard of public safety culture. That's because of hundreds and probably thousands of years of them being exposed to various types of natural disasters, right? So naturally, they form a very close, interest in terms of safety. Everybody knows how to mitigate risks, prevent, for example, even more modern tech terms. For example, of a Japanese car development, right? So they look into safety is very close to their heart. So they are very detailed and very meticulous in preparation of how to mitigate an accident, for example. Okay, or a tsunami. Every school children knows what are the sirens mean. Tsunami, earthquake, volcano eruption, for example. So they know where to go. So they have drills. So these are part of what we call an active approach or positive approach to safety-seeking behavior. And I hope we in Malaysia can actually inculcate this culture and what do you call improve our society's what do you call behavior in terms of safety. Okay, so let me move on to the next one. So after safety culture, we look at also what we expect in terms of health seeking. So just now is prevention mainly. Health seeking is actually what to do after you are injured. For example, you got a snake bite, where should you go? So prior to this, a lot of people, maybe in our grandmother's time, many people will start to look for pawang bomo, pawang ula, and bomo ula, shaman, and so on. But after a while, our system has evolved. Our healthcare system has evolved to become much better, increase in terms of public awareness about health. We see more people now start to go to the hospital rather than going to the alternative medicine. So this is a very important next step where we need to improve our primary and actually hospital care services, so that our public will have the confidence to come and seek treatment. So if they get a good treatment and good outcome after the treatment, they will have what we call increase the confidence in the public to stick to the treatment or to the protocol for health system. So it's a natural what we call vicious cycle. So we've learned from our colleagues in Laos, for example. In the past, a lot of people doesn't want to go to hospital after snake bite because they say everybody goes there, they will die. So they decided to go to the shaman instead. But when they improve the service, for example, by providing the appropriate antivenom in the hospital, when people see some people who got bitten by snake went to the hospital and live, and they go back to their villages and tell them, hey, look, I went to the hospital, excellent service. So now everybody in that village who got bitten by a snake decided to go to the hospital rather than the shaman. So this is another dynamics of how we can actually help improve the health status in our society. But for that to happen, in this segment of appropriate health seeking behavior, the most important component is the healthcare system. So we are part of that healthcare system. So that's why we have this session today to actually improve our knowledge and improve our confidence in managing patients well. Okay, so that our patient will get the optimal service that we can provide. Okay, so what about first aid for snake bite? Now, this is actually mainly in the pre-hospital setting, where patient got bitten and how they react to it. So this is part of also health-seeking behavior and also safety-seeking behavior. So there are two parts of this type of injuries that can happen with snakes. One is from the bite. The other one is without a bite, but also strangulation. And the other one is when the venom enters the eye, what we term as venom ophthalmia. Okay, so in terms of bite and strangulation, we see that people can get injured through those snake bites that has venom. Okay, the snakes has venom, or the snake doesn't have venom. For example, in terms of severe injury from snakes doesn't have venom is from python, reticulated python, for example, is a very big snake and can cause very severe tissue damage from the bite. Okay, the teeth causes a lot of tearing and maceration. Okay, and those which are actually causing venom to enter the body are from the snakes with venom. Mind you that the number of snakes with venom in Malaysia is not as many as those without venom. So the likelihood chance for you to get bitten by a snake with venom will depend on where you are, what is the circumstances, how the incident happened. Okay, so so not all snakes has venom. That's a very important point to think about, because the way we react nowadays in our public is thinking every snake bite is from a venomous snake, and therefore all these snakes were killed. So that is also not good because snake is a very important component of our ecosystem. They help to maintain the balance in all the what we call cycle or food chain. So if they remove quite a high predatory level of animal, then we will have problems in the lower part of the animal kingdom. We have uncontrolled population growth, for example. Yeah, so that can cause more harm to our society as well. Yeah. Okay, so in terms of first aid for such a bite, either venomous or non-venom, snake with venom or snake without venom, we did a bit of a survey from the cases that we were consulted. Rex ASEAN was consulted for each cases in Malaysia. Not all cases, but this is just from the Rex consultation. So we did a small study, cross-sectional study of pre-hospital intervention for snake-related injuries consulted to Rex from 2018 to 2020. That's a 3 years period. So this is our paramedic students research project. So they look at these 3 years, and we found that the total cases, as you can see from year to year, is actually more than 1,000 cases from 2018. And snake bite, snake-related injuries, not just bites, snake-related injuries forms the majority of the consultations. Other consultations are from other animal bites and stings, or poisoning from mushrooms, poisoning from marine animals, for example, okay, and arthropods bites and stings. Okay, so from this data, we found out that the most common group for snake-related injuries are in the age of between 40 to 59. Basically, it's 18 to 39, and the male gender is more predominant. So maybe male is more risk taker or more exposed to the elements. Therefore, they are highly affected compared to the female population. Malaysian forms the majority of the consults for snake-related injuries, and the Malay race is also the highest. That's maybe part of our socio-demography. And from Rex Consult, the most common is we found those 3 years is from Sarawak, followed by Pahang and Perak. This does not mean that other states does not have snake bite or snake-related injuries. It's just that they don't consult as frequent to Rex or use the service provided by Rex. Okay, I'm sure Kedah and Perlis, for example, have a higher number of snake bites, but they just don't, consult to Rex. For geographical area, basically, this is very interesting. This is what I was saying earlier. We found that urban areas where populated areas are actually quite high, almost as high as rural areas in terms of cases of snake-related injuries. So if you are posted in the rural area, maybe you can say that, oh, you are probably better off in the rural area, less snake bite cases. Okay, this because of what I said just now, populated areas provide opportunities for the snakes in terms of food. We provide food for them, and therefore they come for the food. Yeah, you know what I mean. For example, we give food, we just throw away food, and other animals come, and these other animals are food for the snakes. Okay, and there are snakes also food for other snakes, a bigger snake. Okay, so that's very interesting. And the majority of cases are basically in the outdoor setting, yeah, outside of the house. Um, um, House compound. So indoors are mainly in the kitchen, in the bedroom, in the living room. So these are the 3 areas in the house. How do they go into the house? That will depend on how aware our public is about safety. Are they going to sleep with the door open and so on, windows open? These are all areas which a snake see as a potential entry to the house. But most of the time, it can come through the sinkhole, or not sinkhole, the hole where the drainage is. So those are the one of the most frequent areas where if it's not covered, then they can enter the house. In terms of the species diagnosis, most of them are actually unidentified snakebite, and this is because the incident is so fast, so quick, and the snake just ran off. What we can see is only just a color, for example. Sometimes they don't see at all what bit them. So, and there was no camera or phone with camera available. They could not take any pictures. Suddenly they just feel pain and they just run away. Okay. So some of them are actually able to be apprehended, either killed or brought alive to hospital for identification. But some of them also take pictures of the snake that bit them, but without catching or taking or bringing the snake to the hospital. So, and the majority of them, the activities were actually as unidentified snake bite, and the activity is from walking. Okay, so pre-hospital intervention, we see that majority did something to the wound or to the beaten area before arrival to hospital or arrival to a medical care. So the majority of this are inappropriate treatment. So what are they? So the most common is tourniquet. So they apply some ligation to the bit, either proximal or distal to the beaten area, and sometimes not just one but multiple ligation. And this can be very, very tight as well. And depending on the material they use, can actually cause more harm. For example, causing skin laceration, causing reduced blood arterial flow to the distal limb, and therefore predisposed to edema and also possible necrosis as well. So what we always encourage the public to do is just probably do nothing to the beaten area and just minimize movement with or without immobilization, and go to the hospital as soon as possible. So that's all that we advise, a very simple first aid method for the public to remember, rather than doing all kinds of other things. Some of them do things very strangely, not just to themselves, but also to the snake that they caught. Okay, so here you can see majority leave the snake alone, but those who did something to the snake also, they will actually, for example, here you can see, cut the tail of the snake and eat the tail, burn the snake. Some of them cook the snake and eat. Some of them cut open the head of the snake and take out the brain and put on the bitten area. They say that that is an antidote for the venom. For all we know, the snake that bite them is not the venomous snake at all, right? So yeah, one of I think one of the most gruesome first aid that we have encountered as consultant is one case in Sabah where after bitten by a snake, he doesn't know what the snake is. He ran off. So he was so scared that he ran off to the kitchen of his house, take a cleaver, meat cleaver, put on a wooden block and chop off his finger, actually his thumb. So after that, he brought the thumb to the hospital. Okay, unfortunately, we cannot, reattach the thumb, but we did not want to, cause more harm to him. We just say, okay, thank you so much. We'll try and do our best. We didn't tell him that possibly the snake that bite him is a non-venomous snake. He might not, he might not die from that bite in the first place. Therefore, the intervention is, more self-harming than the snake bite itself. Okay, so so that's a very interesting story, I think, and I always bring it to conferences to show the picture, and that's very interesting. Okay, so in summary, appropriate safety-seeking behavior and appropriate health-seeking behavior recommendation. For example, first we need to encourage people to wear proper clothing and going out. Don't wear, don't walk around barefooted. Wear something, protective shoes, for example, or if you're working in the plantation, wear proper boots. And that will actually prevent or help you to from getting injury from snake bites. And then obviously one need to know where to go when what are the number or emergency call that you can get help from. So 999 is our emergency call number, and this I think the public should be made aware of. Okay, 999 is from landline or mobile phone, but if you have no access to landline, then you can use your emergency mobile phone number, right? It's 112, if I'm not mistaken. Okay, and of course, to continue to educate and increase the awareness of the public about safety, and not just about snake bite, but every aspect of safety that we can get to implement the safety culture in our society. And what about the health-seeking behavior? We encourage them to move away from danger, call for help, calm down, remove jewelries, reduce movements, and actually get help in transporting to the emergency department. So we involved with public awareness. So we come up with various types of pamphlets that we share. And this is one of the things that appear in our ebook, Landscape of Medical Significance. The winner of today's Kahoot will get this book, printed version. But everybody else can actually access this book through the ebook version. Okay, so what about venom ophthalmia? That's another injury just now. Just now was about bites. So venom ophthalmia, we just encourage early copious amount of irrigation to the eye. Any clean water, any clean fluid will actually help minimizing the effect of venom on your cornea. So this one is almost specifically in Malaysia, caused by the spitting cobra, equatorial spitting cobra, or Najas sumatrana. There are other cobras that can spit or spray venom, yeah. But in Malaysia, mainly is from Najas sumatrana. We have another Naja species or cobra species called Naja cauthia or monocle cobra. But in Malaysia, our monocle cobra is not reported to frequently spray venom. Okay, they can have some spray, but not as accurate or not as efficient as a Naja Sumatrana. So copious amount of irrigation is sufficient, and this needs to be done in our primary care setting. Okay, don't wait until patient reach the hospital. So even in outside of hospital, if possible, get it irrigated, and even when the patient arrive in your primary care service, get the eye irrigated before sending to the emergency department for further treatment. What about after that? Yeah, there's nothing much that actually a primary care clinic can do in terms of early intervention, other than, for example, irrigation. Maybe can start on tetanus, anti-tetanus toxoid. If patient is more than 10 years, 5 years of the last tetanus shot, and also or unknown, and also to perhaps minimize movement. If they say the patient is bitten on the limb, get it immobilized and then send with ambulance to the hospital. Okay, so there is no role actually for further monitoring of patient in the primary care service, except if, let's say, it's a very remote area. We had cases in Sabah and Sarawak where they can be very difficult to be brought out. Various logistical issues, even in Pahang, for example. So they had to wait quite maybe overnight in where they are, and that's where close monitoring can actually start. So otherwise, in the primary care setting, we say the most important thing to do is to send patient urgently to the emergency department for close serial monitoring, and also, of course, if requiring antivenom or not. So this is one scenario where this is our friend in Vietnam. A patient got bitten by a big snake, and rather than take just a picture of the snake, he decided to bring the live snake to the hospital with him. And this is a king cobra. So as you can see, it's not just yeah, it's nice to see, and you can identify the snake immediately. But you can imagine if this patient bring it to the GP, your setting, right? Your clinic. I think the whole clinic will run out of the clinic. Yeah? So this can be very dangerous, and not just for them, for the patient, but also for others. Okay, so that's why, let's say if we do have patient brought in snake with them, we take a picture and we actually call for help. We call our able APM or bomba service to come and rescue the snake. We don't say catch the snake, we say rescue the snake, because in this setting the snake is the most threatened. Okay. This is not their natural environment, so we rescue the snake. What about the patient? Yes, of course, we will treat the patient once the scenario is safe. So so we have what we call references that we can use. We have the several guidelines that we can use. So but in Malaysia, in our setting currently, what are the things that we can improve to help our primary care service is basically an updated national guide. We have a guideline that was first done in 2017. So it's a high time for us to upgrade or update our national guideline of snake bite management. And also the recent incident of what we call non-indigenous snake bite, means that venomous snake from non-Malaysian. People keep it as pets and they got bitten and they die. So when we look back and we find that there is inadequacy, there are quite significant inadequacy in our so-called wildlife, and we don't have a Dangerous Animal Act in Malaysia. So we hope that this will be updated soon. Okay, and perhaps we can have a Dangerous Animal Act soon to also include how, not just about animal welfare, but how this animal can actually affect the population, our society. So it has to act in balance with protecting animal and also protecting society. For example, that guy who brought a venomous snake from Africa, he died, and we found out that the Wildlife Act does not have this this species of snake in their list. Therefore, they say it's not wrong. That is actually, I think, a big hole in the whole system of how this type of cases should be managed. Anything else? So of course, for example, as I mentioned just now, somebody got bitten, the close serial observation needs to be already done from our primary care, even pre-hospital care. And in terms of what you call looking at the progression of, as I said just now, pain, swelling, those are the main thing. We don't expect the primary care to do blood tests, but if let's say a patient is, we've been guiding KK in remote areas, and they have blood test equipment, we can ask them to take, for example, full blood count and also coagulation profile. So we can, for prolonged observation in their center before able to be transported to the hospital. Okay, so on top of that, we also ask them to observe the progression of the wound, the bitten area. So here you can see an example here, someone who got bitten by a cobra, a Naja species, either Naja cautia or Naja sumatrana. 13 hours post-bite is because it's what we call dermonecrosis. That's one of the earlier signs that we see in a cobra bite, and it progresses over time. Okay, so if you can actually document pictures, that's why Rex Consult is very good, because we can document pictures, not just a verbal call and after that put down, that's it, finish. No, we follow through each case from the time of consult, arrival, hopefully, even before arrival to hospital and until patient is discharged. That could be taking a few days for one case. So we can follow through and also make sure the patient is managed optimally. And of course, wound care, and because you can see the dermonecrosis and so on, this one wound care, not just in this may actually progress in the hospital, but what happened after. So most of the time, sometimes of this dermonecrosis is quite extensive. It will require the debridement, and after a few days of debridement, if patient is well, patient will go for what you call skin grafting. So they will then going to be followed up quite a long time, and they will be required to look by our primary care physicians with regular dressing and so on in the community. So this is where I hope you guys are aware. Patient may not come to you in acute state, but actually a continuous process of providing optimal care in terms of wound care to patient. Okay, so this is another example. The patient is already bitten, debridement done. Here you can see, and skin grafting about 2 weeks after the after debridement, and you can see the progression over 1 month period. How the wound, the skin graft is well received from good care in the primary care service. Okay, so on top of that, we have to adopt technology, and one of our most how should I say most impacted technology we apply now is ultrasound. So we use ultrasound. So not just ultrasound for looking at where the collection of abscess and so on, but also we already employ ultrasound early on to make sure that the patient does not wrongly manage to as compartment syndrome, which is not correct. So we have prevented patients from undergoing unnecessary fasciotomy, early fasciotomy for an injury which does not really involve the compartments. All these bites can mimic compartment syndrome, but it is not compartment syndrome. It's envenoming syndrome, and therefore the management is different. And we use ultrasound to help guide us and our colleagues to see where the extension of the edema is or swelling is, and also, for example, looking at the flow of the blood in the affected limb. And this example this study that we did with our colleagues in Taiwan shows that 100% of patients who go through this procedure did not have to go for a surgical intervention. Compared to before, very high number of patients without ultrasound, they decided to go for so-called impending compartment syndrome and so on. Okay, so So that's how technology has helped in terms of patient's care for unnecessary iatrogenic injury. A patient will definitely stay longer after fascectomy, right? But without surgical intervention like this, a patient can be resolved with a primary optimal care with antivenoms and also antimicrobials. So patient can actually go home faster and earlier. So that helps us in terms of managing costs as well, in terms of hospitalization costs to the patient and also to us as a healthcare service provider. All right, so since I already touched on antivenom, I'll just talk a little bit of antivenom. It's not expected for you as a primary physician to give antivenom in your setting because of various reasons of logistics and also price, and also not all patients will require antivenom immediately. So patient will require some form of observations, some investigations to select the best and most optimal antivenom. But in general, antivenom is still quite a big problem worldwide, where we find that some places have difficult in terms of access to the antivenoms. In Malaysia, we are very lucky. Our health system is rather proactive, and even though we do not produce antivenom, we actually have the appropriate antivenom for our situation, and in enough amount, in sufficient amount. So in our study, we look at all these aspects of antivenom accessibility, and we published it in our recent paper in BMJ. And you can have a look at this later on. I can give you the references through our moderators later. Yeah. So it's very interesting. So there are about 5 other countries that have big problem among the ASEAN countries, but Malaysia and Thailand is rather managing very well. Okay, partly it's because of the health service system that we have. Okay, so we have to thank our KKM, our maybe Ministry of Health as well, and also Education Ministry for a very proactive approach. And we revised our antivenom supply to the appropriate one years ago. Our efforts has paid off. Okay. So these are the appropriate antivenom that is that we import to Malaysia from our neighboring country, Thailand, and they thank God that they're able to produce a bit in excess of their own local need, and therefore they can actually export it. So we actually relying on that. But we expect that if the number of cases increases, demand for antivenom increases, there could be some shortages as well. Okay, we had encountered a few issues with supplies recently because of the horse flu. So the production of antivenom was interrupted, and we struggled a bit, especially from our colleagues in Laos and Indonesia, for example, or Vietnam. So we resort to utilizing expired antivenom instead in situation of emergency and in terms of crisis. And we found that there's no big difference in using expired antivenom compared to the non-expired antivenom. So that's an interesting development. So we are writing a paper on it. So just wait for the paper to be published. So that will be a very strong advocate for such use, rather than throwing everything away after expiry date. We perhaps can consider keeping it for a bit longer in the same situation, same environment for emergency use. Okay. All right. So I've told you just now, we have some guides that we have. I've already given a few tasks to all of you before joining this webinar. I hope you have accomplished the tasks before joining us, so that you can form some idea and also some queries for us to discuss during the forum. Okay, so these are the 2 books. One is the guideline, which we will actually need to update, and our landscape. That one is the 2nd edition. Now we have the 3rd edition. So the price is for the Kahoot is the 3rd edition of the landscape. And for your information, this effort is not just from REX alone. It's actually a collaboration of multiple institutions, especially, for example, with KKM. We also work very closely with the MyBase in Malaysian Biodiversity Information System from FRIM. And we have, of course, the National Poison Center also working very closely with us. And in terms of international collaboration, we have the Malaysian Society on Toxinology, the Toxinology Society of Indonesia, and the Philippines Toxicology Society, and all Toxinology Society. And we actually have what we call increase our number of consultants, REX consultants in Malaysia. And I hope our primary care physicians are aware about this, and they can actually consult REX. And maybe our UKM family medicine group can actually spearhead this connection with REX, so that we can actually help our our primary physicians, family medicine physicians, if they had cases, they need some consultation, they can call us, okay, or communicate with us. And in terms of other efforts, we have to look at improving the knowledge and awareness in our society, our public, through what we call as myth busting, and from our collaboration with various groups. These are NGOs. It's called ID ULA Malaysia. It's available on Facebook, and KLXOPES also advocating what we call first aid, appropriate first aids, and prevention of inappropriate first aid in the public. And we conduct courses. For example, FACTS, these are open to the public. First aid course for snake bites, and also various other courses that we are now starting again after the pandemic. So hope many of you can actually attend these courses in the near future. Okay, so I think that's all from me. With that, I thank you. We are now going to proceed with, I think, the what do you call, forum. Am I right? Back to you, our moderators. Thank you.
Thank you, Prof. Khaldun. So we are going to start with the Q&A session. We have a few questions typed in the chat box. If you have any question, please feel free to unmute yourself. We would allow you to unmute yourself now, and you can ask directly, or if you want to type, also you can. So the first question will be from Praveen Kumar. He asked, my question is the management of snake bite from KK setting in Kedah. Number one, do we need to inform REX? And number two, late management will delay prognosis. Will it be better having antivenom in KK setting since Kedah has the highest snake bite in Malaysia? Thank you.
Okay, thank you so much. First question, the answer is no. It's no compulsion for you to consult REX in KK setting. You can actually consult to the hospital that is you are liaising with. For example, your tertiary referral center hospital, most likely the emergency physician in the hospital. So you can liaise with them. There's no rule or saying that you must consult REX. No. Okay. But if you want to, you can actually contact Poison Center, and they will direct you to one of our REX consultant. Okay. I am sure everybody has a Poison Center hotline number. Okay. Number two, what was the question again?
It was whether it is better to have antivenom in KK setting because late management will delay the prognosis, will cause worse prognosis. And since Kedah has high snake bite incidence.
No, the answer is no, because of that's not where the patient is going to be monitored. KK setting is to identify and just make sure patient is stable and sent to the appropriate emergency department. So it's not in the KK setting. You can't do much in KK. So what you need to do is just to make sure patient is safe and transport. So there's no role for antivenom in KK setting. it takes time for you to, prepare antivenom, give antivenom, and then not just that, you have to monitor also after giving antivenom. And if, let's say, patient has severe reaction to antivenom in your setting, that can actually cause more difficulty for you. So that's why KK, we don't stop antivenom in KK unless it's a KK that is very, very far away. I know that Kelantan, for example, had 1 or 2 KK very, very pendalaman. So I'm not sure that their KK also has a doctor station with them. So most of the KK, sometimes they don't have a doctor with them. They have MA and nurses. But in Kelantan, for example, they have reserved, I think, 1 or 2 of the KK, which is very, very far in pendalaman. Okay, so that can actually, patient can stay with them very long. So we still don't encourage, but it's the decision by the state where they want to place the antivenom. But from our experience, it's not really conducive, and it can actually lead to wastage as well. Okay, so it's best just KK standardize your treatment to stabilizing patient and send to the appropriate emergency medicine, the emergency department. But do all snake bite needs to be referred to emergency department? The answer is, of course, no. If, let's say, you have a snake bite that is confirmed to be a non-venomous snake, there's no reason why you need to send to emergency department. You can actually manage by what you call wound care, and maybe some pain relief and short observation and discharge the patient with TCA. Okay, but most of the time, as I said just now in our study, most of the snake bite is unidentified snake bite, and that can actually pose a danger. So even though patient do not have any sign and symptoms, but it's unidentified snake bite, patient should go for undergo close serial observation for at least 24 to 48 hours, and that cannot happen in KK setting, right? So depending on the situation, if you say you can get the snake identified immediately, then there's a possibility that the patient does not need a transfer. But on the safe side, it's best to just prepare for a transfer to the emergency department, what they call in a safer environment for managing the patient.
So, Prof, if let's say if we are able to identify if the dead snake was brought to the KK and we consulted with Rex with the proper pictures and all, and it was confirmed to be, let's say, something non-venomous.
Yes.
So, unless patient has severe local symptom, they can be discharged home.
Yes, we've done this also with some KK in Sabah, for example, or in Sarawak, which they attach to the Rex group. So the staff in the KK is also in the Rex group of that particular hospital, and they do a consultation very early. So we help them in terms of whether to transfer or not to transfer the patient.
I see.
That is very helpful. So that's why I said liaise with your referral hospital. Maybe you can be added as physician, as doctors, you can be added to the Rex Consult group for that particular hospital.
I see.
From the KK side.
Because we have a question from the participant. If the snake is unidentifiable or not identifiable, so is it best to send a patient to hospital?
Yes.
No rule of keeping and discharging.
Don't wait.
Okay.
We don't wait until patient has a problem, then only send. Because the problem there is already stated, which is unidentified snake bite. So that itself already warrant patient for at least 24 hours observation, which cannot be done in KK.
Okay. A follow-up question from the same participant. They said some emergency department asked us to describe the snake bite mark. Is it useful clinically?
I would say yes, it can, but you don't rely on 2 puncture wounds to say that it is a snake bite with venom, because there are snakes which can bite with 2 puncture wounds, but they are not venomous. Okay, and there are bites which are only 1 puncture, or not even a puncture, just a scratch, but it actually comes from a venomous snake. So there are many features of the bite, especially on human skin, that is not correctly interpreted and wrongly insinuated in, for example, studies of they ask the snake to bite a piece of paper and then they take a picture of the bite mark on the paper, which is different dynamics to how snake bite a human in life, right? They are moving and we are moving. So the way we get injured on our skin is different from imprinting, a bite from a snake on the paper. So that's why those type of guide is very misleading and very dangerous. It can cause, as you say, like this, misinterpretation and causing a false sense of security. And therefore, some of the decision can actually lead to a very serious disaster to the patient. Okay, so no, the answer is it can be, but it's not the primary way of how we interpret whether this is a bite from a venomous snake or non-venomous snake.
Okay.
Okay.
We have a question from Faisal Hakimi. He asked, adakah betul antivenom untuk sea snake adalah sangat mahal? And number 2, adakah betul bisa Tropidolemus vagleri dianggap lemah? Thank you.
Okay, so the first question, sea snake antivenom, yes. Sea snake antivenom is imported from Australia. We do not, as I said, we do not manufacture antivenom. It's imported from Australia, and the only one that produces sea snake antivenom is from Australia. So we imported them, and yes, we actually have quite a good experience in actually utilizing or using sea snake antivenom in Malaysia. And with good results. Okay, yes, it is important to have sea snake antivenom, even though the number of cases of sea snake envenoming is not as high, for example, compared to other elapids, for example, cobra. But the antivenom itself is very expensive. So it's true, the most expensive antivenom that we have or we import is actually for sea snake antivenom. It costs maybe 5 or 6 times more expensive compared to antivenom for cobra, for example. Okay, so I'm not going to tell you how much it is, but because it's it fluctuates every time because of exchange. Now it's becoming more expensive because our ringgit is perhaps not as strong, so the imports can be quite expensive. Yeah, but that's one of the other reason why we have to really have a very good knowledge on the indications of giving antivenom, how much to give, how to give, and preventing wastage and so on. Yeah, so that's where REX comes into play, where we can help our physicians and doctors to treat the patient well in terms of antivenom management. And the second question is Tropidolemus vagleri, or what we call as temple pit viper, is very common in Penang. That's the totem, or you go to Penang Snake Temple, you will find Tropidolemus vagleri. It's a pit viper, and all pit vipers are venomous. It contains venom, but the venom is highly specific for certain organisms. So they are actually very potent, very dangerous to birds and to mice, but apparently it does not cause much harm to human. So I hope that answered the question. Even though you are bitten by a pit viper, and if it is a Tropidolemus vagleri, you may get local, limited local signs and symptoms of pain, local swelling. But we have not encountered anyone yet who developed coagulopathy from Tropidolemus species bite in Malaysia. Okay, so soon there will be a paper coming out as well. There's a study done looking at REX data. So we classify the bite from Tropidolemus vagleri is a venomous bite. Okay, sorry, it's a venomous snake. Okay, but the bite hazard level is considered as what do you call that just now? Harmless or not dangerous? Not dangerous. Okay, yeah.
But do they still need hospital observation?
Of course. So that is just the effect of venom. There could also be other effect from the bite, right? You have a mechanical injury, so you still have risk to tetanus, you still have risk of secondary infection. You can, look at some progression of the edema, pain, and so on. So it's not what we see not dangerous is directly in terms of the effect of venom, okay, but not the effect of the bite. So there's a lot of people think that, oh, it's classified as not dangerous, therefore we don't have to go to hospital. Next thing we know, 1 week later he developed tetanus, right? So it's not from the venom, but it's from the injury itself. So that's why we say if you have injury from snake, just get to medical care as soon as possible. Don't stay at home and wait. And for example, in this case, he think it's a Tropidilemmus bagderi, therefore no problem. Yes, the majority of them go home without much what do you call issues. Mostly just pain relief and also dressing of the wound, prevent secondary infection. Not even antibiotics, but most of them do get a booster of ATT, right? And that will protect them for the next 5 years.
Prof, speaking of ATT, if the patient is suspected of being bitten by a hematotoxic sort of snake, is it safe without knowing the coagulation profile to give at KK level before sent to hospital, or should we wait?
There's the thing that we advise is to prevent any IM injection or arterial puncture before knowing the coagulation status of the patient. Nice. For such bite. So there's no real how should I say urgent need for you to give ATT after a bite. If you understand the pathophysiology and also the pharmacology of how ATT works, it's not for immediate absorption. We are not giving immunoglobulin. So that's a different thing. So tetanus immunoglobulin acts immediately like antivenom, right? When you have actually already had the tetanus. But in terms of ATT toxoid, it's actually just a booster. And the booster can be given much later. And the effect of the booster to build up your immunity is not immediate. It takes a few weeks actually. So that is not the urgent thing to consider. Means the patient got bitten, straight away give ATT. That's not the way how it should be practiced. Okay. And always ask when was your last ATT. So if it's still within the 5-year period coverage, then there's no need for ATT. So this is like becoming already automatic in, for example, primary care. We see a lot in KK, for example, even before the patient say anything, they already been given ATT. Even without asking the status of patient's previous vaccination for tetanus toxoid, right? And this is not just for snake bite. This is for any trauma, motor vehicle accidents on. Hari ni jatuh bagi. 1 minggu lagi jatuh bagi lagi, so it's very kind of a wastage,
like a reflex.
Yeah, so we need to have a thinking primary care service for this type of things to resolve.
Okay, Prof, next question. Kasut kuning boots, Wellington boots, adakah sesuai kerja di sektor peladangan bagi mengelakkan patukan ular?
Yeah. Tu pocukangnya kasut. Okay, yes.
So when we go hiking and go places in the hutan and all, we should ideally be wearing this kind of protection, is it?
No, that's the thing. You have to tailor your what you wear to your activity. Okay. So these Wellington boots are mainly for slow movement and in ladang and also plantation, but not for hiking. For hiking, you need to move fast. That Wellington can be not gripping well. So what you need is boots, so proper boots. But for hiking and outdoor activities and line, you can also consider, if you don't have Wellington, you can have a pad. There's a shin pad that you can wear. It's not just a pad. Sometimes it's just a very thick fabric that you wear above the shoe line to your knees. So you can tie. So that is for kind of prevention in terms of snake bite, where the snake cannot penetrate that material. Okay, so you can buy this. That's another option. I think that's the better option compared to just wear Wellington boot to every activity that you use. So there are many protective gears that you can actually use. But that's for the leg. right? But where you put your hand when you go around, when you do hiking and so on, sometimes you capai dahan and so on. What that one, some people say wear glove, yeah, but some glove they can still penetrate, and that's not conducive as well. But what you need to do is just to have a very good eye where you want to hold your, the branches before you hold them or whatever you touch. Okay, don't put your hand into unnecessary places as well. Okay.
Okay, Prof. Next question. What is the proper management in rural KK setting without medical officer before referring to tertiary hospital?
It's just that you make sure that the patient is vital sign is okay. Calm the patient down. Immobilize the affected area. Okay, if it is bleeding, then of course you apply the bleeding protocol. Put a pressure and then balut. But in general, for snake bite, we don't balut. We just immobilize, put a clean cloth over it or gauze, and then you can actually transfer the patient to a hospital.
Okay.
If patient has severe pain, yeah, that's another thing. Just now we talked about ATT, but another reactive action is to give IM injection of analgesia, Voltaren, or even hydrocot, Piriton. Actually, unnecessary. There's no reason why you should give this so-called steroids and also antihistamines, because patient doesn't have any sign and symptoms of anaphylaxis or allergic reaction, right? So they think that any animal bite, it can cause anaphylaxis, which is wrong. Okay, so this is another thing that we have difficulty also in reversing the practice. So it's automatic already. The three things that they give: ATT, Voltaren, hydrocot Piriton.
Adik kan ayat sejuk lah. Ayat sejuk, ayat tak demam lah.
Okay.
Okay. Next question. Hello.
Yeah.
Okay, so any other questions?
Yeah, we have a few number of other questions. Okay, if someone had sucked the bite site, especially traditional treatment, and found out that the snake it is venomous, do we still need to refer the patient to emergency? Any observation? I think the answer is
yeah, I've already answered
yes,
that
right.
just now, so
okay.
You don't have to.
Next question will be, what are the ultrasound findings of compartment syndrome?
So ultrasound, it's not compartment syndrome. What we see in ultrasound is musculoskeletal ultrasound. When we do, so what we do, we look for is the cobblestone sign in soft tissue edema, which is most commonly affecting snake bite and venoming. Okay, when they spread, the spread is actually in the subcutaneous tissue, not in the intracompartmental muscles area. So you can look at this so-called collection of fluids in terms of edema in both places. But in terms of snake bite, most of the time we see is only in the subcutaneous tissue, not in the compartment area, not in the muscle. The myositis also can cause myositis, inflammation of the muscle after an injury or trauma, or even a snake bite deep enough into the muscle can cause myositis. But we see most of the time in snake bite is in the subcutaneous tissue only. Okay, that includes the fatty area. And we use this ultrasound also to guide us to determine the what we call rate of proximal progression of the edema. The edema in venoming is progressing proximally. It follows the lymphatic tissue spread. Okay, so it doesn't, well, it can move distally, but that's not the real problem. The real problem is that when you have a lymphatic flow proximally, that will return to the heart, and that goes into a circulation that becomes systemic envenoming. So from local through lymphatic to the heart, then goes to systemic. So from the local area, if you can actually monitor the progression of the edema hourly, then we can convert that progression at the fixed time interval to what we call rate of proximal progression. That's where we give you one of the video for you to have a look what rate of proximal progression is about. That will tell you how the venom is still progressing or not, and this edema is progressing through damage of the basement membrane between tissues through what we call the metalloproteinaceous toxins or in the venom. So that will facilitate the spread of other toxins through the tissue. Okay, and some of them actually cause cytotoxic damage as well, causing what we call as dermonecrosis as the venom spread. So that's where we monitor these changes closely so that we can guide us to give antivenom or to repeat an antivenom dose if necessary. And another blood test that we can use, because it's a tissue destruction, right? So it affects our CK level, creatine kinase, not creatinine kinase. That's not in the kidney, but creatine kinase, CPK, creatine phosphokinase. That actually has a byproduct of tissue destruction. So if the trend of CK is increasing, rising together with the state of cytotoxic effect locally through the dermonecrosis, then we say, yeah, possibly there's a role for a top-up dose of antivenom. Otherwise, if CPK is actually in reducing trend, then we know that this tissue destruction is already, over and completed, and we don't need to give further antivenom.
Okay, Prof. Next question is, good afternoon, Prof. I would like to clarification for this. In PEACE protocol for pre-hospital care, it is suggested that if the snake was killed, to bring it along to health facility in a secure container. But from my reading, snakes can still envenomate after death. So some people might not know that, and wouldn't the lack of precaution while handling the dead snake will expose the handler to the danger of envenomation as well?
Yeah, we don't ask you to handle the snake. We ask you to take a picture of the snake. So we don't ask you to pick it out and play around with it. And no, that's not how we identify snake. We just ask you to put the snake, on a piece of paper, for example, on the Macintosh, and then take a picture with a ruler next to it. It doesn't, how should I say? Yeah, we see this what we call videos, people chopping off the snake head, and the snake head that when he holds it, it still can bite in defense. Okay, so that's that can happen, but that's a freshly killed snake, not like for several hours already. So the risk is of course much lower. Okay, but in terms of handling snake, we always say call APM and call Bomba for it. Don't put in the bottle yourself, so that it kind of increase your risk of getting bitten from the snake. Okay, yeah, so be safe.
Okay, Prof. Next question. Do we have Telegram group for REX for referral and reference?
No, we are actually, the consultation to REX is using WhatsApp. So we have WhatsApp group. I know it's a bit limited. Telegram has no limits in terms of numbers, but so far the current setup is using WhatsApp. Maybe in the future we will have REX, what we call app. We are actually trying to develop, still in beta mode. There's some bugs still hiccup here and there, but we can't proceed it, and we don't have the funds to develop. So we still have the intention to have an app on its own. It's more secure, privacy and so on, right? But at the moment, we just use what we have best at the moment so far. Is at the moment is using WhatsApp. So you just need to get into the WhatsApp group for that particular hospital.
Okay. Next question. Do we need to irrigate all snake bite wounds before transferring to the hospital?
The answer is no. If it's, let's say, it's time consuming, there's no need for you to irrigate every wound. You just need maybe cover or even immobilize the wound, the limb. That's all. There's no really real hurry to irrigate the wound unless it's very, very big. And even then, if you do irrigation for such a big wound, you can actually increase pain, bleeding, and also possible wasting time as well. So we've seen the bite by python can cause quite extensive wound. If you don't cover the wound well with, for example, some pressure, it will actually bleed quite a lot. So that kind of irrigation and so on will be best done in a controlled environment in the emergency department rather than in the primary care service.
Okay, Prof. The next question. In KK, if patient come complaining of being bitten by don't know which animal, causing pain and swallowing, and for example, during sleep, Okay. Can we treat as snake bite or other animal like scorpion, centipede, or spider?
So you get if there's no animal that you can identify, you can classify it just an unidentified animal bite or sting. So that falls in the category of unidentified. So that's where close monitoring is important. So we look at closely monitoring for any sign and symptoms, clinical signs and symptoms, and we treat through the what we call symptomatic approach. So that requires you to transfer the patient.
I see. Okay, Prof. What are the protective pads for the shin available?
There are many brands. You can go to Shopee and buy. So I don't have to tell you exact brand. I'm not the marketing agent.
Okay,
So,
okay.
but there are many various types of pads that you can use, either synthetic or even hardened plastic. So you can buy it online. You can just go and look for snake protective gear or pads. You can choose whichever you like.
Okay, Prof. Next question. Salam, Prof. Berdasarkan pengalaman, how long normally it takes for patient to show systemic envenomation? Yang kedua, betulkah patient yang dipatuk ular tedung selah akan lumpuh dalam masa setengah jam?
The answer is number one, how fast? It's very subjective. Depends on the species and depends on how much venom is included in the body, how active you are after bitten. So those are the things that will determine the speed of progression, right? So of course, more movement, lari-lari, massage the area and so on, that will increase the spread of venom from local to systemic. And then the second question, betulkah after 30 minutes for king cobra? We have seen king cobra sign and symptoms as early as 15 minutes. Okay, so he got bitten on the neck, and then he take garlic and sapu around the area, and then only go to hospital. That's within less than 15 minutes, and he got sign and symptoms of ptosis, difficulty breathing, and so on. So it doesn't have to be that. It's depending on what bit you. This guy got bitten by king cobra. So it's a big snake, and high amount of venom is injected, right? So it can present early. Depends on the snake species as well. Some of them, for example, cobra, we've seen a child. After 15 minutes also, they have already signs of the collapse in the car while traveling to the hospital. GCS was 3, we had to intubate, we had to do CPR, and we had to give antivenom while doing CPR. And patient opened the eye 30 minutes after the CPR, within the CPR itself. So that was interesting, patient intubated, CPR suddenly opened the eyes, so it's because of the muscle paralysis has been neutralized with the antivenom given during the CPR. So time is relative. You don't think, oh, I'm bitten by a king cobra. If I go to hospital too early, maybe okay. That's not correct. So if you got bitten, just go to the hospital. Don't have to wait.
All right. Next question. Do we give antibiotic to all patients with snake bite? If yes, which antibiotic? Thank you.
The answer is no. Not all snake bite require antibiotic. It's only indicated for certain conditions where antibiotics is indicated. Okay, if you don't have any skin necrosis, tissue problems showing signs of secondary infection, there's no reason why you want to give antibiotics. There are two ways you give antibiotics. One is prophylaxis. Okay, one is for treatment. We don't give prophylaxis. Okay, we give for treatment. Similarly, with the hydrocot and Piriton just now, we don't give for prophylaxis against allergic reaction. We give it to treat allergic reaction. Okay. So there are, however, situation of snakebite where we give as prophylaxis. For example, just now it's a very extensive tissue necrosis. That is actually, we know, will harbor, potential media for secondary growth, either from your own commensal or actually introduced from the snake bite itself, right? From the fang and so on. So we have seen many of these bite, for example, from Naja species. I showed you just now the demonecrosis, right? So we grow most frequently we grow Morganella morganii. Okay, so the thing is about Morganella morganii, some of it already resistant to our antibiotics. So some of them were given augmentin or cloxacillin as first line. Then after the culture came back, either from the blood culture or from the tissue culture, we had to change to third generation cephalosporin. So, but we only change after we have evidence for us to change lah. If it is still working with augmentin and cloxal, for example, we continue. But if it shows there's a sensitivity issue, then we change to the one that it is sensitive to lah. So that's where culture sensitivity can help us in managing the patient better with the appropriate antivenom. Okay.
Okay. I think the last question,
Okay.
does sea snake bite happen in Malaysia? As sea snake bite is painless when we need to suspect sea snake bite when beside patients swimming in sea.
It's very difficult. The only thing that you have to understand, sea snake bite occur not so much in the sea.
Oh.
The sea snake bite is when the snake is outside the water. And how does this happen? It's happen when they are caught. They are caught in the fisherman net. They are, try to be removed from the net. For example, when they are stuck, some of them kick the snake off their prahu and so on. So these are all activities above and outside the sea. There's no such thing as the snake in the sea where you jump or diver or snorkel diving, the snake come and chase you in the sea. No, and bite you. No. That doesn't happen. The sea snakes are very much quite docile, and they are maybe quite curious, but not really dangerous because they don't see you as food. Okay, unless they are threatened lah. Don't go and chase the snake lah, kan, in the sea. No, but they are actually most of the cases of sea snake bite in Malaysia we have encountered from fishermen. Okay, because of, as I said just now, they are caught in the net and they want to remove it or throw away. You can see some of them just pick it up and throw away. Yes, they are a bit floppy above water, but if they are in pain or they can still turn around and bite you. So the bite can be painless, but the person who got bitten most likely know that they have got bitten already lah, because they see got bitten. And some of them decided that to continue working on the ship or on the prahu or in the fishing boat, and they normally will actually complain of muscle pain, fatigue. The urine becomes dark, or we call dark urine, or myoglobinuria, and also of course some difficulty breathing a bit later. So they will be showing signs of rhabdomyolysis and also neurotoxicity. But the earlier ones is normally myotoxicity signs.
Okay. Bro, I think that's all the questions from the participant, but I have two questions for myself. Number one is if the snake spray venom and it came into contact with our broken skin or our mucous membrane which has an ulcer in the mouth, so what do we do?
And well, first of all, you don't suck the wound, kan?
Okay.
But again, you need to see if that ulcer and so on is big enough to absorb the venom significantly, but unlikely it will stay up in the ulcerated area for long. Most likely you will swallow, and that will be digested by your own stomach enzyme. So that kind of renders the so-called venom inactive already lah. So the risk is actually very small. Unless you cut your skin and you pour
venom
of venom into it, then you're looking for trouble lah.
Okay.
Okay.
So in this case, do they need to be observed in a hospital?
If it is significant, yes. I mean, very short observation, depending on what venom that they suck as well.
Okay. My second question is, Prof, if a patient presented late, let's say 12 to 24 hours after a bite with no hematotoxic or neurotoxic symptoms with an unidentified snake bite.
What about local symptom?
Local symptom, maybe not so much, just a 2-bite mark there. So in that case, do they still need to be observed in the hospital? Is there a sort of time frame, like after how long no symptom we can let them go home?
I mean, again, observation wise, it's actually 24 to 48 hours after the incident. So you can
Okay.
calculate from that.
Okay. So as
So
long as
if
they
there is,
haven't,
yeah, if there is still extra of that not
For-
achieving the 48 hour, then might as well continue to observe to complete it. Better be safe than sorry lah. Yeah.
Okay. Some participant is asking, is there any emergency contact number that we can call to handle snake apart from bomba? Just bomba number?
999. No,
99.
we in Malaysia we are very universal. We
Just
just
199,
use
yeah?
1999. Yes.
Okay.
All right.
Okay. If there's no further question from participant, we will move on to our next session, which is Kahoot quiz. But before that, we would like to share a video about this wonderful publication by none other than Prof. Khaldun. So Nasmi, maybe you can play the video.
So the winner of the Kahoot will get this book, right?
Yes.
Okay. Good luck. All the best.
Okay, so thank you, Nasmi, for the video. So next we will start the Kahoot quiz. So can everybody take out their device, go to kahoot.it. We will show the questions and the quiz right now. When you are in kahoot.it, please key this game pin 4174047 and we will start the Kahoot quiz. Okay, we'll start with there are a total of 12 questions. The first question is, so who is number 1? Number 3 is Aimi. Number 2 is Y. And number 1 is Adiani. Congratulations, Adiani. You are the winner of the wonderful book written by Prof. Khaldun. Okay, so that's the end of our Kahoot quiz. So we are towards the end of a session. Before we end, is Prof still around? Would you like to give any closing remarks before we end and show the CPD point for everybody to scan?
Congratulations, Adiani. So can you give your details to Rihui or the moderators so that we can either post.
Okay.
We don't know who you are, but we can either post it to you, or if you are in HUKM or UKM, we can actually pass it to you by hand. Okay, so Rui, I congratulate all our moderators. Thank you so much for inviting me, and I hope everybody had a good time this afternoon.
Thank you, Prof. Khaldun. Thank you so
thank
much
you.
for giving us your wisdom on snake bites.
Do you want to take pictures of everybody here?
Sure.
Yeah,
We should.
so
This
we have 242 participants.
Yes.
That's
Whoever
unusual.
is able to turn on the video, please do. We will start taking the pictures lah. Thank you for attending. We will show the QR code shortly after we take the pictures. Nasmi, maybe can you help to...
Where is Aimi as well? What, Amir, what's her name?
Yeah.
Who won?
Adiani.
Adiani, yeah.
Okay, I'll pick the first page first. Smile. Next page, smile.
Please keep smiling as we have 10 pages to go through.
Wow.
Okay,
I
next
didn't realize
page.
a lot of people had time to attend this afternoon.
Yeah. It's a very interesting topic. I think that's why.
Yeah.
Okay.
Congratulations, everyone. And we are recording, right? So if we're recording, then maybe later we can share the recording as well.
Okay.
I will upload it to the YouTube later.
Okay, sure, Prof.
Okay.
Okay, so we are going to share the QR code for the CPD point for Malaysian doctors. You can use the MMA app to scan and get a CPD point. So thank you everyone for attending this afternoon's webinar. I hope you all everyone had a good time. Thank you again to Prof. Khaldun for gracing us with your presence.
Okay. Yeah. So anybody coming for coffee after this?
Oh yeah, that one we will have to discuss with Rama first. Rama has yet to let us know. Okay, Prof, we will get back to you.
Okay.